Okay, are we online?
Yep.
Okay. Well, thanks everyone. Welcome to our Clinical Immunology Society Case Conference webinar series for the month of December. My name is Andy Snow. I'm one of your co-moderators from the Uniformed Services University in Bethesda, Maryland, and I'm joined by Dr. Monica Lawrence, who's from the University of Virginia. And as always, we'd like to thank both USIDNet and LACID for their generous support of this series. Tonight, we're going to forego our usual brief literature review and our diagnostic labs segment and dive right into two very interesting cases. I just want to remind everyone before we dive into the cases that as each case is presented, we encourage the audience to send your questions or your comments on the case throughout by using the chat box in the lower left-hand corner of your screen. So without further ado, our first case is actually going to be from my co-moderator, Dr. Monica Lawrence at the University of Virginia Medical School. And we're very pleased to have none other than CIS President, Dr. Jordan Orange, as our senior mentor for the case. He's the professor of pediatrics at the Baylor College of Medicine. So I'll let Monica take it away.
All right, thanks, Andy. I actually don't see my slides. Do you see them on your screen?
I see a small version of them, but I don't see the full screen.
Morgan. Oh, there we go.
There we go.
All right. Okay, so as Andy said, we're going to do a case here, and the case is, one of the main points is the discussion at the end, so I encourage you to chime in with your thoughts during the case, but then also save some time for the discussion at the end. So this case is a 27-year-old young woman who came to our clinic to reestablish care with us for CVID. She'd been seen as a young child and then gotten care elsewhere and was coming back. As a child, she was told that she had recurrent upper respiratory infections, but nothing particularly severe, no hospitalizations, no atypical infections, no real red flags. However, a concerned family member did research and requested that she have immunoglobulins checked and was found remarkably to have undetectable serum immunoglobulins from what she can recall. I don't have those actual records, but that's what she was told. And so she began receiving IVIG at age 12 years and has been on immunoglobulin replacement now with sub-Q since that time. She did, interestingly, have the onset of alopecia universalis starting kind of around puberty. And other than that, though, no autoimmunity whatsoever. No thyroid disease, no arthritis, no other signs of autoimmunity. And since starting on immunoglobulin replacement has been remarkably infection-free except for one episode of salmonella the year prior to coming to see me that required an inpatient admission, a slightly prolonged course of antibiotics, but she recovered from that. Review of the rest of her medical history, family history was unremarkable. And on her physical exam, the only abnormality was her alopecia. She was wearing a wig and had absence of eyebrows, eyelashes, or any body hair. Looking at her lab work, the basic labs, her complete blood count was completely unremarkable with absolutely no cytopenias and a normal white blood cell count differential. Her metabolic panel was normal, and she had normal thyroid studies, In the chart, she did have a positive antithyroperoxidase antibody, but hard to know what to make of that since that was done while she was on IVIG.
So maybe we should pause there for a minute and just review what we know so far. So lack of serum antibodies early on and the strange presentation of alopecia. Are there any thoughts from the audience or from Dr. Orange at this point before we look at any immunological workup? We have one comment from Michael Keller in Washington, STAT1 gain of function. Interesting thought. And Dr. Abraham at the Mayo Clinic suggesting NF-kappa B2. That's definitely an interesting possibility. Dr. Orange, do you have any comments at this point, or should we move on to the immunological workup? Oh, we do have a question.
I would definitely move on.
We do have one question from Dr. Walter. To any nail findings? I guess anything unusual?
Her nails were normal, and Dr. Rosenzweig would be so upset. I did not look at her hair, her fake hair underneath the microscope. But no, skin was normal.
Okay. Well, if there are no further questions at this point, why don't we move on?
Okay. So this is her flow cytometry. It's notable for a complete absence of CD19 positive B cells. That was confirmed using CD20, 21 as well. So no B cells. And in her T cell compartment, she had an inversion of her CD4 to CD8 ratio, and then she had sort of low end of normal NK cell numbers. And her immunoglobulins, sorry for that typo there, while on IVIG, showed an IgG, which was repleted to the normal range, and then otherwise absence of A, M, or E.
Okay.
You want me to keep going, Andy?
I suppose, yeah. So obviously the new knowledge is the severe B cell deficiency here. Are there any other thoughts from the audience before we move on?
Well, the only thing that I would add in is, so quite clearly this is a substantive immunoglobulin deficiency. Is everyone aware of the new ICON, not so new, but the ICON consensus document for CVID? That might be worth just recounting.
Sure.
I mean, just so that, CVID, as we certainly all appreciate, is it's a definition. It's a definition that has encompassed different things at different times, and it continues to do so. Right now, there are several different sets of diagnostic criteria for CVID, and again, the ICON document, which is probably the most recent to offer a series of diagnostic criteria, differs from some of the others. And it's in a subtle way, but it's worth mentioning. Certainly this patient would fit those criteria, but that the ESID criteria and the American criteria per the practice parameter has always left the door open to patients that have low IgG and impaired antibody quality, whereas the ICON document is really clear in that you have to have low IgA and or low IgM in addition to low IgG, in addition to impaired antibody quality, to be called CVID, and that really nothing else can be called CVID, and that anybody that had been called CVID that really just had low IgG and impaired specific antibody is now to be classified as something else. So I think it's worth just recounting that.
Thank you, Dr. Orange.
So in this case, obviously she meets the criteria, but yeah. So At this point, I was thinking along the lines of what Dr. Keller was thinking. So just to summarize, it's a 27-year-old female, alopecia areata, recurrent infections, absent B cells, low normal NK cells, and A-gamma globulinemia at a young age. So at this point, I was thinking about stat 1. I was thinking about, could this just be, all she had was alopecia along with her antibody deficiency, so not a ton of autoimmunity, so no fungal infections. So the question that I was faced with is one I think a lot of us see in clinic, which is this just the broad term CVID, or is this a true syndromic PID? And if I think it's syndromic, then what's the best approach for how to diagnose this patient? Should we send off the whole exome? Should we do a targeted panel for known genes? Should I Sanger sequence specific genes of concern? And we'll get into that discussion, I guess, at the end, Andy, or do you want me to go ahead and go?
Yeah, I guess so. We do have, there's one, I think, pertinent question from Dr. Vess in Cape Town about whether this might be, an unusual XLA case, right, with a severe B-cell deficiency and serum Ig deficiency. Was there any thought given to sort of an atypical X-linked gamma globulinemia?
Yeah, certainly it's possible. Obviously, you'd have to invoke some sort of kind of viewing, some lionization, something like that, but absolutely.
Okay.
So based on, at this point, I went ahead and went with exome sequencing because I couldn't feel confident in any particular targeted gene to do for Sanger sequencing. And so we went ahead with the exome sequence using a trio with her parents. And the exome sequencing revealed a de novo heterozygous mutation in exon 23 of the NF-kappa B2 gene. And this is not a variant that had previously been recorded. However, nearby variants have been reported in association with this clinical phenotype, and the in silico analysis predicted that this would be a damaging mutation. And just to review the literature of this defect, so there was in the initial report was in the American Journal of Human Genetics in 2013, and in those patients, the 4 individuals reported had premature stop codon mutations, so slightly different than this patient, which was a missense mutation. Those patients had the premature stop codon, and they were characterized by antibody deficiency, normal or near normal B cells, alopecia, and then all of them, interestingly, had central adrenal insufficiency. However, subsequently, a year later, there was a paper discussing 3 patients with an autosomal dominant missense mutation, which led to a less severe antibody deficiency, absence of B cells, alopecia, but without any autoimmunity, including without any adrenal insufficiency. And I think, Andy, you were going to go through why that might be, the difference in the defect.
Sure. Just, I don't want to put anyone to sleep with the basic biology here, but it's an interesting case. So Dr. Lawrence's case appears to be closest to that latter report she mentioned of the missense mutation that Dr. Chris Goodnow and Matt Cook in Australia reported. And the way this works is that anything that basically prevents the phosphorylation of both of those serines at the end of the NF-kappa B2 protein, which encodes the P100 family member of NF-kappa B, anything that disrupts that phosphorylation prevents the proteolytic cleavage of P100 into its active P52 product, that forms a heterodimer with rel-B and constitutes the non-canonical NF-kappa B signaling pathway. So part of the phenotype is likely linked to a loss, maybe a 50% reduction in sort of non-canonical NF-kappa B signaling. But there are two different pathways for NF-kappa B activation. Non-canonical, which we typically think of downstream of CD40 and BAFF receptor, and then the canonical signaling pathway that involves rel-A heterodimers, and that's downstream of things like the B-cell receptor. And the interesting thing about this and Dr. Lawrence's case is because that serine is mutated, the loss of phosphorylation prevents the cleavage of P100. And Alex Hoffman and some of his colleagues showed a number of years ago that P100 actually acts like sort of a fourth version of the inhibitor of kappa B protein that normally sequesters canonical NF-kappa B in the cytoplasm. So what is thought to be happening here is that not only do you have a loss or reduction in non-canonical signaling, but you have dominant interference with the canonical signaling pathway. And it's known from primarily from studies in mice that if you knock out both canonical and non-canonical signaling, you result in a severe B-cell deficiency, and in humans, alopecia as well. So I just thought that was just interesting to know, because other mutations that result in premature stop codons and truncated versions of the protein don't present with this quite a severe B-cell deficiency. And Dr. Goodnow and his colleagues sort of speculated that that was because that truncated form of P100 doesn't inhibit the canonical pathway as well. And so that's just a little bit of insight into how the mechanism here behind the molecular defect.
Great, thank you, Anne, for that explanation. So now that we have heard a little bit about this case, I thought we could use this as a little bit of a springboard for a discussion about when you might want to think about genetic testing in patients who present with quote-unquote CVID. And so as a starting point for the discussion, and I'd love to hear Dr. Orange's thoughts as well as anyone in the audience, is this paper from Dr. Cunningham-Rundles and Dr. Casanova, in which they took 50 patients with CVID who had at least one of the following criteria, either being early onset, defined as less than age 10, having autoimmune manifestations, low B cells, and or a family history of hypogammaglobulinemia. So in this case, obviously, this patient meets, 3 of those 4 criteria. And in those selected subjects, they actually had a 30% hit rate using kind of a targeted next-gen sequencing panel. So that was one approach to sort of increase the yield of when you might want to send testing. So with that as a springboard for discussion, I guess I'll turn it over to Dr. Orange for his comments on what his approach is to choosing patients to send testing, and then anyone else in the audience.
Well, thanks for that, Monica. That's really a lovely case and a really important illustration of some of where we are at the cutting edge with really old diagnoses, so to speak. And with the question being, how do we use exome sequencing in this diagnosis? I think first to take a quick step back, these NF-kappa B variants in common variable immune deficiency. And I think that the book is not yet closed on all of that. And I think we suffer a little bit from looking specifically into particular cohorts. And so the paper that we're referring to now, as well as the discovery paper, is one that really has focused on CVID specifically, and that this variant can be found within the variant of NF-kappa B2 can be found within CVID. We look in large databases like EXAC and things like that, and find that it's not found very much elsewhere. But what's interesting is that when you look at immune disease overall, and when you look at other potential rare disease cohorts, so you increase your signal of rarity, you actually do find some of these things. And so I think the full spectrum of what many of our genes do that we associate with disease, this one, NF-kappa B1 more prominently actually, we're going to find that they're associated with things other than what we initially label them with. And I'll just mention that in our cohorts, we've now identified 9 NF-kappa B2 variants, and only 2 of them are in CVID patients. And what's interesting is that, and the other 7 being in immunodeficiency-related diagnoses. And I think what's interesting is that when you are approaching the diagnosis of primary immune deficiency with perhaps less bias as to what your what your initial cohort is, you potentially are linking to what we like to now call immunophenotypic expansions. Okay, so with that said, we heard a little bit about this paper. I will mention we had a paper that came online relatively recently that represents an unbiased approach to exome-based diagnosis, and presents the first 280 families that we screened with a variety of diagnoses. And 20 of these patients had CVID, and of those 20, actually 8 were solved with a genetic diagnosis. And so that's about a 40% diagnosis rate. And there was no pre-selection to any of these particular things, other than just that the physicians had referred them for genetic diagnosis. And so I would make the case in some ways that your pretest probability is perhaps still the best guiding principle, is that when you think that this is likely to have a more profound signal and explanation, that you're almost likely to be right. So that's kind of one message. The other is that in the paper that, again, it's first author is Stray Peterson. It's in JACI online. It'll be in the January print edition. But the other thing is that there are certain factors that improve the diagnosis when you obtain exome sequencing. And so in this paper, all comers, all diagnoses, we had, if we had only the proband, there was a 36% diagnostic rate. But if we had the proband and at least one healthy relative, there was a 43% diagnosis rate. And surprisingly, if we had a full trio, it really didn't change. It was a 42% diagnosis rate. So that there was, at least from this exercise, and we're now up to over 1,000 individuals, and the numbers do change a bit, and we'll update those at some point. But basically, being able to do more than just the proband gives you some power, and when you look at it, maybe even as high as a 20% increase in diagnostic rate. As far as where to go with using genetic diagnosis, one of the things we did in this particular paper is we looked across primary immune deficiency diagnoses, and we found that some are higher yield than others. I don't know that I would use that as a guiding principle. Again, only to say that I think when your pretest probability, when your index of suspicion is high, that may be the best feature that we have available to us now. So I'll just offer those few comments, and I know that that's not any specific criteria. The other is a financial criteria, and I know we have callers from all over the globe, but in the United States, I think that there is certainly a case to be made that when you do not have a single or one of 2 gene candidates that you might approach by direct sequencing or a simple next-gen panel, that there becomes a value to performing exome sequencing. And that value equation is changing daily as the cost of the test gets less. But the Clinical Immunology Society Advocacy Committee will be offering the results of a survey that was performed of the CIS membership, as well as a practice paper on how to approach the use of genetic diagnostic testing in a managed environment in which we exist mostly in the United States. So I'll stop talking, but thank everyone for participating and for their support of the CIS, and of course to the wonderful presentation that we just heard.
Well, thanks very much, Dr. Orange. Before we move on to the next case, I see a few questions that maybe you could comment on as well from sort of a pragmatic perspective. We have two folks attending that are, concerned about the expense for sequencing, and that, often there's not an ideal panel to order, and it's difficult sometimes to figure out who's paying for it. Do you have any, comments on that for folks that, may not have the luxury of ordering whole exome right away, or whether CIS has any means of
I would say, absolutely. So I would say to Anthony and to Jean that we hear you, and we hear you loudly and clearly, and that payers don't necessarily appreciate where the cutting edge of our field is, nor do they appreciate the value proposition in obtaining particular types of tests. And one of the things, again, that this practice paper is focused on is when is it appropriate to, from a value standpoint, when is it appropriate to pursue individual sequencing, when is it appropriate to pursue next-gen panel sequencing, and when is it more appropriate to go right to exome sequencing. And hopefully that'll provide us all as practicing immunologists something that we're able to take to our payers to advocate for our patients without taking days out of our lives to protest decisions that in some cases don't make a whole lot of sense. So more on that soon.
Okay, great. Well, I think that...
No. Oh, Andy?
Yeah.
It's Alexandra. I'm supposed to talk about the next case, but I just had one comment about this one, if that's okay too.
Sure.
Okay. Yeah, thanks. I just had, I just wanted to mention that some patients that I actually saw today, so they were on my mind as Jordan was talking about that, about how the phenotype is kind of expanding, just because I saw them today. So we follow we referred a girl with disseminated MAC and a 7-year-old who had whole exome sequencing when all the typical mutations were ruled out and was found to have an NF-kappa B1 mutation. So it's kind of an unusual presentation of that because it's supposed to also be more of the CVID pattern and autoimmunity. But then her mom actually, when we started talking to the mother, she had all the classic findings of CVID but hadn't been diagnosed with that. So it's just kind of showing that the use of whole exome sequencing, where the mom was diagnosed after the child who had an unusual presentation, but then both have NF-kappa B1 on the spectrum as well.
Well, thanks, Dr. Freeman. That's very helpful. So, so in the interest of time, we should probably move on to the next case. Thank you so much to Dr. Lawrence and Dr. Orange for their insightful comments and the presentation of this last case. So both Dr. Lawrence and I will sort of co-moderate the second case we have for you tonight, and it comes from Dr. David Buchbinder, Pediatric Hematologist at the Children's Hospital of Orange County in Southern California. And we're delighted to have Dr. Alexandra Freeman, as you just heard, a staff clinician at the Laboratory of Clinical Infectious Diseases at NIAID here in Bethesda. And so I will let Dr. Buchbinder take it away.
All right. Thanks, everybody. So I'll start off with a quick story about two young ladies that came to see us in our clinic. Right. So they came to us. They were referred by their pediatricians for, again, pretty unremarkable, by what we consider cytopenias, and we'll show you guys the labs. But the first sister was a 16-year-old female. They were both Latinas. The first sister, again, had been previously completely healthy, had never been hospitalized or anything. And again, she was sent to us for evaluation of pretty mild cytopenias. The second sister, likewise, was a Latina, 12-year-old female, previously healthy. And she only had a history of some mild scoliosis that had not required any surgical intervention or bracing or anything. Also, likewise, she had been sent to us for an evaluation of cytopenias. Again, the past medical history was, as I said, fairly unremarkable, nothing impressive. They weren't on any medications. They didn't have any allergies. The family history I'll cover in a subsequent slide, and that's sort of what made us hang on to this family and sort of explore them in greater depth. And actually, when you looked at the young ladies, their physical exams were completely normal. I don't know if there's anything in particular that people would like to know about their physical exams, but they certainly did not have any, again, congenital anomalies. They didn't have any weird fingernails. They didn't have any leukoplakia or any other sort of strange things, neuroorganomegaly, adenopathy, really nothing. So interestingly, the dad's history was way more striking. So the dad, again, was in his mid-40s. He's a Latino. He was not the product of a consanguineous union. He had this interesting history of having had cysts that, and he wasn't very descriptive, but he did have a history of cysts that occurred in his groin and buttocks. He did note that he had his first surgery at about 17 years of age in Mexico. From the sound of it and the description of it, what he had described was really hidradenitis suppurativa. He had some other really strange sort of historical pieces. He had a bout of airway edema that occurred at an outside hospital, required actually a tracheostomy that had been removed at the time that I saw the family. Interestingly, he did have a history of, I believe it was his father, had a history, we'll get to his parents, but he actually himself had a personal history of had required a bone marrow exam for cytopenias. Again, I couldn't get my hands on the sort of records or slides of that. But his other striking piece of history was he had been diagnosed, and he was a fairly young man, with anorectal carcinoma and had been treated with multimodal therapy, including chemotherapy, radiation, and surgery. And again, so that was sort of, again, a very striking history. And interestingly, his parents were alive. His father actually had low blood counts. Again, details were not really available for that other than what he had said. And he actually had 6 siblings, a mixture of males and females, and all of his siblings were all alive. Really no history of, family histories of other cancer issues, nobody with infectious issues, nobody with autoimmune disease. And again, that was sort of the history that really made us interested in the girls. So it was more the father. And so these were the basic complete blood cell counts for the 2 girls. The first sister, you can see, very unremarkable. I mean, I think if this showed up at any, hematologist or oncologist or immunologist, people probably wouldn't get very excited. But the first sisters, you can see the CBC was completely normal. She had some very mild macrocytosis, but again, I don't think anybody would, I think you wouldn't be excited about it. Her neutrophil count was beautiful. Her lymphocyte count was beautiful. Monocyte count was beautiful. And the second sister, equally, again, I don't think anybody would get super excited, but she was a little bit more interesting. She was a bit more anemic, a little bit more leukopenic. Also, again, she was pretty much normocytic. And it was a hypoproliferative anemia. She had a retic count of 2.9%, with a hemoglobin of 8.5. She had very mild to moderate neutropenia, very unimpressive. Her lymphocyte count was also a little bit depressed, and her monocyte count was also a little bit depressed. But again, I think if anybody looked at these labs, they might have even accidentally been discharged from our clinic with follow-up at their pediatrician. So, and I think, so we ended up doing a little bit more investigation because of, again, the dad's history. The kids' histories were, again, pretty unremarkable, but again, dad's history was kind of weird. So you can see on this first sister, the one with normal blood counts, she had, again, a slightly, kind of skewed, a little bit low in the CD19 number. B cells were a little bit low, and the rest of everything else, looked pretty unremarkable. The sister with the more severe cytopenias with the more profound anemia had, again, also a depressed number of B cells. She also had a little bit of a CD4 lymphopenia, and those were again, the results of some basic lymphocyte immunophenotyping that was done on the girls.
So maybe we should, well, why don't you go to the next slide, and then maybe we should take some
I'll show
questions
the
from
twigs.
the
And
audience.
again, immunoglobulins were unremarkable in both sisters. We just did some basic immunological workup. And you can see, in terms of antibody responses, not too bad. For the ones that we typically check for, we did some basic lymphocyte proliferation studies. Everything looked fairly unremarkable as well. So that was sort of what we were left with.
So maybe at this
stop there, I can continue on, but
maybe at this point we could, so we have
bone marrow results.
Well, whatever you think. I mean, maybe. So so we have some thoughts coming in from our audience. So few different. So we've a couple questions. Let's go to those first. So did you check the ratio of naive to memory T cells in the immune workup?
We did not. So that was not done.
Okay. What about telomeres? Were those checked?
Yeah, no, we did look at telomere length, and those were normal. We sent them to repeat diagnostics in Vancouver, so it's our pretty standard. And telomere length with the full panel, the 6-panel, was normal. That was considered. And we also looked at Fanconi anemia. We looked at breakage studies. That was another quick study that was done. We did not do skin fibroblasts. We just did peripheral lymphocytes for the breakage studies.
How about what are people thinking with the low B cells and the really normal? It's not a little high in some of them immune globulin levels too. That helps.
So we have one
of the differential.
Yeah.
One for GATA2?
We've got one vote for GATA2, which is a good thought. Any other ideas from the audience?
Yeah.
Icaros.
Yeah, Mayhagelin, again, we didn't see any, like giant platelets or, we did look at the peripheral blood smear. There wasn't any, again, no large platelets, no, inclusion bodies or that sort of thing. We did not look at those other two. Icaros and MHC class 2 expression was not evaluated.
Yeah. Okay, well, so we've got some
questions about the physical. Oh, I was going to say other questions about the physical exam in terms of the rectal cancer too. Any history of warts to go with the, along with the GATA2?
So
for any of them?
Yeah, no. So in again, the two sisters had not had any HPV-related issues. The father, again, if in retrospect, yes, we were able to. It was an HPV-associated, rectal carcinoma. But again, the dad is fairly unsophisticated. I think so I don't know that we would have gotten that piece of history from the get-go, but, in retrospect, yes, he did have HPV-related issues as a teenager.
Mm-hmm.
So certainly increasing the GATA2 question, I guess, or some other sort of whim thing or some other thing associated with HPV-associated issues. And there was no history of congenital heart disease in either the young ladies or the father. Yeah, no congenital anomalies by history. We did not screen. We did not do any echocardiograms. We did not do a renal ultrasound. So I don't know if other people would have done those. That would have been an interesting question. And the two young ladies are completely symptomless.
So no infectious etiology either, no.
Nope.
Okay.
And these were, again, their blood counts were done when they're healthy, so they weren't sick. They didn't.
And I think Dad was symptoms, right?
Yeah, Dad. Dad had a complex history, but when he would bring his girls in and we would talk to Dad, he didn't seem to, aside from his, cancer history and, again, he certainly had a lot of issues. Dad did not have any evidence of lymphedema, neither did either of the two young ladies.
But that's a great question.
Yeah. And I believe we did look for autoantibodies, and we did not detect any in the young ladies. I don't know about the dad. I don't know if he was ever screened for any autoantibodies. And the other request for anergic B cells count, I do not have that.
Okay. Well, so we have a lot of good questions, and obviously an interest in GATA2 here. But I guess we can move on to the bone marrow results.
Sure. So we did marrows on both young ladies, and they were normal karyotypes. They were hypocellular, and so the first sister with the better blood counts had a little bit lower cellularity. The one with the worst blood counts had actually better cellularity. Our pathologist said, they look normal, trilineage hematopoiesis, no increase in blasts. We did some, as I had mentioned before, we had done some basic bone marrow failure workups, pieces, and as I recall, our pathologist actually was more fixated on, he thought that he had seen a lot of mast cells in one of the sisters' bone marrows. So that sort of became the focus, and I think it sort of, and so I think pieces of the actual marrow exam got lost in sort of people were focused in on other aspects of the bone marrow. But I'll show you some slides of the bone marrow a little bit later. But again, it was looked at, it was read out, it was other than some basic hypocellularity, it was sort of unremarkable.
So that doesn't sound like WHIM in terms of other autosomal-dominant diseases with neutropenia and infections.
We have one thought about CTLA-4. I don't know if that was considered.
Yeah, it wasn't. Again, I don't.
Yeah,
we did not think about CTLA-4.
Yeah, certainly doesn't sound as severe. So.
Yeah, right, and I think with CTLA-4, you often see more, a lower IgG in the, more bowel disease and the brain issues and things like that too, than the dramatic kind of cytopenias like this. I mean, the cytopenias with that are more autoimmune related.
Right. Okay, well, perhaps we should move on. I know time is...
So, looks like
ADA2
brought up
deficiency. ADA2 deficiency is a really good one to throw out there because that can have pancytopenia, ADA2 deficiency, and neutropenia. But it does seem like this is more of a the autosomal dominant pattern. That's an interesting thought. In terms, I think we're realizing more and more with the ADA2 deficient patients how many of them have pancytopenias and kind of some of them even now, really early in childhood have had remarkable bone marrow failure. Although the classic presentation that was initially described was kind of the vasculitis and the strokes.
We did not do any testing for ADA2 deficiency, and we did not look at PI3K issues either.
Okay, well, why don't we go ahead and move on to next slide.
So, we, out of interest, we went ahead and, so this was, again, the summary is we had two sisters that were referred for evaluation of pretty unimpressive cytopenias. The dad, again, was certainly far more interesting based on his history of hidradenitis, laryngeal edema of unknown etiology, his history of cytopenias, and then, of course, his anorectal carcinoma in a 40-year-old gentleman. Again, very striking history. That was very strange. And then, of course, so we thought, well, possibly something, in the realm of immunodeficiency. So we ended up doing a little bit of some testing, and of course, we found some aberrations, including B-cell lymphopenia, and then one of the sisters had a little bit of some monocytopenia and CD4 lymphopenia as well. So we ended up doing a basic, a lot of our marrow failure kids end up getting some basic, stuff that we can get quickly through insurance companies. Most people don't. Going back to the last case and the discussion, how many of these people should get next-gen sequencing sort of approaches, but we ended up doing one. And of course, we ended up hitting GATA2 deficiency, which actually brought up, so we actually had to cull through the case and went back to the case and really sort of, I think, brought out a couple of points that I thought, I think were really missed by, our team and our group of clinicians. So I'll show you guys the marrow because I thought the marrow when we went back to it was just striking. But anyway, so she had a deleterious mutation in GATA2, certainly consistent with disease. And subsequently, we did find that both of the sisters carried the same aberration in GATA2, and certainly the dad does as well. So this was actually a picture from the marrow, but really just striking dysplasia, which was kind of, it was sad that this was sort of missed because we were focused in on, I think, other aspects of the bone marrow exam. But these sort of large megakaryocytes with, they almost look like osteoclasts, and there were tons of them. I think you could, again, it was very striking. The other lineages were not so impressive. If you look at the myeloid cells, I didn't take any pictures of them because they weren't that impressive. Perhaps you could psych yourself into thinking that there was some, subtle, dysplastic features in the myeloid lineage, but or in the sort of red cell production. But again, striking, the megakaryocytes were very striking, and certainly what's described in GATA2 related bone marrow disorder. So I think that sort of piece should have probably led to a targeted approach looking at GATA2, but I don't know if anybody has comments on that. But anyway, so that was sort of a striking sort of piece to the story that I think came after the actual diagnosis was made. And then I can finish the story just because I think it. So her father, again, is currently at NIH undergoing, I don't know if he probably has not received his transplant yet, but he's hopefully going to be undergoing a MAT-CIV transplant very shortly. And hopefully he's in a disease state from his anorectal carcinoma that is negative for active disease. So the opportunity of, window of opportunity is open for him. And then we are holding on to the two girls right now to get dad through transplant, and then hopefully both sisters will go on to receive a haploidentical transplant in the future as well. And so obviously questions arise as far as when should the girls be transplanted, and but again, the plan is to move them to transplant too, even though they're relatively asymptomatic. But so if people have comments on that. But that's sort of where we're at with the family.
We do, yeah, that is a terrific case. We do have a question from Dr. Hayward who asked, given the heterogeneity you see with GATA2 deficiency, and perhaps Dr. Freeman can comment as well, how do you know in the girls that have a relatively, mild phenotype here whether transplant's the right answer?
Yeah, no, I think it's a difficult question.
Right. No, I think that's a question that that we struggle with a lot. There's a transplanter that that we work closely with, who's involved in kind of evaluations of these patients, and the concern is always that you can see a marrow that just has a little bit of dysplasia, and then suddenly can evolve pretty quickly into leukemia, and the prognosis then can be, is much worse than when you're going into transplant. So I would say one of those siblings had, I've met the dad, I haven't met the kids, but I've heard about them. I was actually at a transplant meeting today where they were discussing them. And one of the kids has much more significant marrow findings and cytopenias than the other one. So, so that's kind of concerning in terms of, whether or not dysplasia will occur. But what looks like someone was just commenting about is we do a lot of the cytogenetic screening for these patients and following their marrows. And once you see some cytogenetic abnormalities, then we're much quicker to move them up to transplant. But I think it's a good question and it's hard. And I think our group has been burned by that too, you know, where you don't immediately go right to transplant and then things progress more quickly than you expect. You know, and I think also this is a good example of where that we see fairly frequently in these multi-generation GATA2 deficient families where each generation seems to have a little bit of a worse presentation. So the grandfather in this case probably had the disease, you know, but his presentation wasn't as severe as his son, you know, who now has a more severe presentation with the rectal cancer in his early 40s and, you know, more significant problems. And then the concern is whether or not the next generation could be even more severe because of other kind of, you know, somatic mutations as well that can lead to, you know, more to leukemias. But, and these patients have not had trouble with mycobacteria, and that's why they're now put on azithromycin to try to prevent some of the infections, some of the mycobacteria infections. I think the main thing is that screening. You know, often we'll also see the monocyte counts start going up, you know, as they're beginning to develop some dysplasia. You can look at the MCVs start going, increasing as well. Oh, wait. There's a question about the, you know, from Australia, from Dr. Ziegler about the matched sibling donor versus the haplo. You know, the transplant approach that they're using for these patients with the haplo, they're using the haploidentical with post-transplant cyclophosphamide, and the individuals are doing really well. You know, we're using the same approach for these patients and for the DOCK8 deficient patients in terms of haplo protocol. And they've actually been quite successful in terms of you know, the overall prognosis. We're not seeing big differences. And then Mike is asking me about using Gardasil. We do. So we do try to vaccinate them when they're younger. So some of the kids, you know, are vaccinated pretty early with Gardasil, and then we're also vaccinating all these patients post-transplant with Gardasil as well, both for them as well as, you know, I'm involved with the DOCK8 transplants a little bit more, but it's the same group that transplants them both. So, and, you know, for both of those diseases, we try to do some early HPV vaccination, although for DOCK8, we move quicker to transplant. I don't know if it's of any benefit, but that makes another question there, but it has very little downside. And there is a potential benefit of preventing the spread of the HPV disease. But, you know, with the HPV, you know, what types of HPV are there compared to what's covered in the vaccine? I think, you know, we haven't done that much. We're trying to start working on that, at least for the DOCK8 patients and hopefully for the GATA2 later, actually looking at the types of HPV. But I think we're going to see a much broader group of HPV and some funny types that might not be as much protected by the vaccine. But I do think there's very little downside, and there's been some potential reason to believe it might help the spread of the HPV disease, even when it's there. But that's why Mike has to give us some nice T cells to help us fight that infection.
Okay, Mike, you're on watch.
So,
you know, so Monica and I were chatting before the webinar. One thing we were talking about with this case, this was a missense mutation, right? And so the phenotype, if I'm not mistaken, you know, is obviously it's a lot milder compared to, you know, these null mutations where you see more severe infection and whatnot. Do you think this is then, you know, sort of more common than we think? Do you have any advice on, you know, going after GATA2 on patients with these mild cytopenias, or?
You know, it seems like it's not rare at all for me. I feel like everyone
right.
seems to have this. So I don't know. You know, I think it's being more and more diagnosed. And, you know, this is also a disease that, you know, our group initially was the one that called this monoMAC. We had the referral bias that we were seeing the patients with disseminated MAC. So we were seeing the patients that had more of the infections. But if
right.
you look at kind of the other initial reports, you know, it was the familial leukemias, and then as someone said with the lymphedema, it was the leukemia with the lymphedema, you know, Emberger syndrome. So I I think that it had a much broader phenotype than, kind of some of us in our little silos were recognizing initially. There's also been a lot of childhood neutropenia as well that's been described in some of the European series. So I do think it's probably more frequent than we're realizing. And it's also fairly, it's become much better known, obviously, since it wasn't described all that long ago, but it's still not super well known. And, it's still being missed in places, and then we hear about it later. So I think we're going to start seeing it more and more, and we're going to see more of a kind of these variable presentations. But, it's concerning. I mean, this guy is, in his 40s, he already had a malignancy. Although he hasn't had bad infections, the infections often don't come until they're in their 20s and 30s and 40s anyways. And we've seen, as I said, some of the generations, the oldest member we'll see, has had almost no infections, and then we'll see their children with really severe earlier onset infections. So it seems to kind of worsen with each generation as well. Some of that is secondary hit.
Right. Well, this case is definitely illustrative then. I think, thanks so much to David and Dr. Freeman for their comments. I mean, I think this is, really interesting example of sort of, thinking about something like ADA2 in a, at least starting with the sisters in a fairly mild form. Should be keeping our eyes open, I guess, for more, being more common, I think. So, okay, well, go ahead, Alex.
Yeah, go ahead. No. I was just going to say that, unfortunately, the dad just had a perf diverticulate, which was probably related to some of the radiation that he had received. So he just got a colostomy last week, but he's still on for transplant in a few weeks. So hopefully all will be well. Okay.
Cool. Well, with that, I think I see we are 1 minute before time here in our hour. We're not going over tonight. So I just want to thank our presenters, Dr. Lawrence and Dr. Buchbinder, and our senior mentors, Dr. Freeman and Dr. Orange. And before we close, I'll just remind everyone in the audience that we are constantly looking for interesting cases. So please, if you have a case we might be interested in and you're willing to present it in the webinar, we have plenty of open slots to consider after the new year. So with that, I'll thank everyone for joining us and wish everyone happy holidays.
Thank you.
Okay. Thank you. Good night.
Thanks, everyone.
All right.
Thanks. Bye.
Bye.